I'm Dr. Sarah Hurvitz, Professor of Medicine and Head of the Breast Cancer Clinical Trials Program at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. The treatment paradigm for ER-positive metastatic breast cancer has changed a lot in the last decade. It used to be that we primarily treated patients with tamoxifen, which blocks the estrogen receptor. Then in the 90s came the aromatase inhibitors, which decrease estrogen levels in the blood. And then even more recently than that, the era of fulvestrant or estrogen receptor down regulators, which are injections that both block the estrogen receptor and stop its production. So all of these therapies are very effective at controlling metastatic ER-positive breast cancer. However, the chance of having a very robust response in terms of shrinkage of the tumor or complete disappearance of the tumors in the body is somewhat modest. And the outcomes show that the length of time a patient will likely have disease control with one of these agents in the metastatic setting is on the order of a year or just over a year. However, in 2012, we had the development and approval of a drug called everolimus, which targets another pathway that is active in ER-positive breast cancer called the PI3 kinase AKT mTOR pathway. And when added to an aromatase inhibitor, it was shown to substantially improve the length of time women could live with ER-positive metastatic breast cancer, extending the time before they needed to switch to chemo. And then starting in 2015, we had the development and approval of 3 cyclin-dependent kinase 4/6 inhibitors, CDK4/6 inhibitors, palbociclib, ribociclib, and abemaciclib. These agents have really changed the way we treat ER-positive metastatic breast cancer and now are the gold standard way that we treat patients when they're first diagnosed with ER-positive metastatic disease or when their disease has progressed on single-agent endocrine therapy, because it has led to response rates and disease control rates, progression-free survival, and now even overall survival benefits that are profound and actually looking better than chemotherapy. So when one considers when should we use chemotherapy for ER-positive metastatic breast cancer, the answer is usually it should be used after exhausting all of the hormonally targeted approaches that are now available. And when we do switch to it, we have to keep in mind the toxicity profile and talk to patients about what is their goal, what sort of toxicity are they willing to live with? Is it willing to come into the infusion room, willing to have a port placed, willing to lose one's hair? I tend to go for gentler approaches like capecitabine and other agents that tend to allow a woman to be out of the infusion room and preserve their hair. And we do have some interesting oral taxane therapies that may be approved in the next year or so based on promising phase 3 data that indicates, we may be able to give patients taxane-based therapy in the metastatic setting without the hair loss and infusion room necessities as well as neuropathy. So I think it's a promising time for us to be evaluating treatments for ER-positive metastatic breast cancer. I think the survival overall is improving for patients with this disease. And I encourage all my colleagues to delay the use of chemotherapy as long as possible.